Today we're going to talk about the Chapter 9 guidelines for 2017. These are diseases of the circulatory system, and there are not a lot of changes, one primary one which we'll talk about towards the end of the podcast. The one thing that changed was more of a clarification when the term with is used in the alphabetic index. ICD-10 is assuming a causal relationship between hypertension and heart involvement, and between hypertension and kidney involvement. And the way that's known is that you'll have that term with in the alphabetic index. These conditions can be coded as related even in the absence of provider documentation explicitly linking them, unless the documentation states the conditions are unrelated. It's almost a reversal of what we've had with some codes in the past. For hypertension and the conditions that aren't linked by relational terms, such as with, provider documentation has to link them. In other words, if you had hypertension and perhaps an eye disease, you couldn't assume that relationship unless the doctor told you they were related. The first coding guideline we're going to look at is hypertension with heart disease. This is very common to find in the hospital, someone who has both hypertension and heart disease, and sometimes associated heart failure. And the codes that you choose are based upon how the treatment is directed. This particular example, the treatment is directed at the hypertensive heart disease and not at the heart failure. So the hypertensive heart disease would be your principal diagnosis. And I have there the index pathway, how we found it, and note that we are coding the heart failure as well as the hypertensive heart disease with heart failure. Hypertensive chronic kidney disease, this is another one of those where you are assuming a relationship unless the doctor tells you there's not a relationship. The patient's admitted with stage 4 chronic kidney disease, which you will also be coding. Hypertension, kidney with Stage 1 through Stage 4 chronic kidney disease is the principal diagnosis, HIT220.221, and we also code which stage of the chronic kidney disease. This is telling us in our coding guideline the appropriate code from category N18 is your secondary code. That's used with a code from category I12 to identify the stage. If a patient had these things as well as acute kidney failure, you would code the acute kidney failure. I'm showing you this slide. I had watched it in a podcast that AHIMA had published recently, and it shows all the different manifestations of chronic kidney disease. There's really very few body systems that it does not affect. And I just wanted to put this here to underline for you how important it is that chronic kidney disease is properly treated and followed. And here's the guideline regarding hypertensive heart and chronic kidney disease. This patient has hypertensive heart and kidney disease with congestive heart failure and stage 2 chronic kidney disease. These codes all together fall into a category code called I13, which is a combination code for the hypertensive heart disease and the chronic kidney disease. The main term you're going to look up is hypertension, but the next subterm is cardiorenal, where you've combined those two terms for the heart and the kidney. This patient has heart failure, so that would be included, as well as the chronic kidney disease. The next guideline is hypertensive cerebrovascular disease. This is when you have things going on in the brain, the cerebro, the vascular system in the brain. This particular patient has a rupture of a cerebral aneurysm caused by malignant hypertension. If you look at the index at the term hypertension, malignant is just a non-essential modifier. It doesn't change the code. It just means it's hypertension. But this treatment is going to be directed at the aneurysm, and therefore it would be your principal diagnosis. And I have there the different paths that the index sends you down until you finally get to the code you need. The reason why you get that fourth character of an 8 with your I60 category is that it does not tell us what part of the brain, what part of the cerebrum has an aneurysm, so we choose the term specified, because there are other choices there in that list of codes that identify exactly what part of the cerebrum is involved, which vessels. Don't forget to include your hypertension code as well as the manifestation of the hypertension, which in this case is the aneurysm. The next code is hypertensive retinopathy. This is when the patient has hypertensive retinopathy and the treatment is directed to the retinopathy. If the treatment were directed to the hypertension, the hypertensive code would be the principal, but because treatment is directed to the retinopathy code is the principal. We know that because in our coding guideline it tells us sequencing is based on the reason for the encounter. It also tells us that subcategory H35.0 has to be used with a code from category I10 through I15, which is hypertensive disease codes. Really, if you follow your guidelines meticulously, picking up on every hint to an additional code or how to sequence your codes, you'll make very few errors in coding. What tends to happen as we get more familiar with the code book, we don't pay as much attention to the guidelines, and then we get in trouble. That includes veteran coders who don't pay attention to updates in the guidelines. That's why so much time is spent on educating coders in the field when these guidelines come out so that things aren't missed. The next guideline has to do with hypertension that is secondary, meaning it's been caused by something else. This particular scenario, the patient has renovascular hypertension due to renal artery atherosclerosis, and treatment is directed at the renal artery. Here in the index pathway, I show you the different ways you get to their codes. There is a specific code for renovascular hypertension. Our guideline tells us 2 codes are required, one to identify the underlying etiology and one from category I15 to identify the hypertension. The underlying etiology is the arteriosclerosis of the renal artery, and the hypertensive code is I15. This next guideline has to do with transient hypertension. This is hypertension that in a patient who is not normally hypertensive. And the case I have here in the scenario is a patient is admitted for a transurethral prostatectomy due to enlarged prostate with urinary retention. His blood pressure is elevated, however, he has no prior diagnosis of hypertension. The guideline tells us you're going to assign the code R03.0 for an elevated blood pressure reading without diagnosis of hypertension, along with your codes that are describing why the patient has been admitted. He's admitted because of that enlarged prostate, which is causing the urinary retention, and for whatever reason he has this elevated blood pressure reading. So I have pick the code for enlarged prostate with lower urinary tract symptoms, and that's N40.1, and there's an instructional note under that code that says use additional code for associated symptoms when specified. Our scenario did describe urinary retention, which is an R33.8 code, and then we add the elevated blood pressure reading as an additional code. The enlarged prostate is the principal diagnosis because it is tied to the principal procedure, the prostatectomy. The patient is having the prostatectomy because of the enlarged prostate. You always have to have medical necessity with the procedure. This is just an aside. So with your prostatectomy, what's your medical necessity? The enlarged prostate in 40.1. And here's the new guideline for 2017 for hypertensive crisis. Assign a code from category I16 for documented hypertensive urgency, hypertensive emergency, or unspecified hypertensive crisis. You will code also any identified hypertensive disease, which would fall between the category I10 through category I15. The sequencing in this case would be based on the reason for the encounter. This slide shows some definitions of hypertensive urgency versus hypertensive emergency. Urgency is a high blood pressure reading 180/110 or higher with no damage to the body's organs. The blood pressure is going to be brought down safely within a few hours with medication. A hypertensive emergency is when the blood pressure is so high that organ damage can occur or is occurring. And in this case, the blood pressure has to be reduced immediately to prevent imminent organ damage, and this is typically done in an ICU. Just as a reminder, the coder cannot assign codes based upon the blood pressure readings. Let's say the physician says the patient's hypertensive, and you see a 180 over 110 or 120, and you think, oh, I'm going to code hypertensive urgency. You can't do that. The physician has to document whether it's hypertensive crisis, hypertensive urgency, or hypertensive emergency. Likewise, when you're reading, let's just say, for example, a lab on a chart and it shows a lot of bacteria in the urine, but the physician hasn't commented on the patient having a urinary tract infection, you cannot code a urinary tract infection. Now, you could write a query to the doctor, depending on your relationship and what's been done historically in the hospital, and just say that you've noticed this high bacterial count in the urine. Does he want to say something, or she want to say something? But sometimes that's driven by what's typical in your facility. So when you get hired as a coder, pay attention to those conversations you have with your supervisor when she or he will tell you when a query is expected in your institution. Okay, now let's look at an example. The patient was admitted to the ER, diagnosed with hypertensive emergency. I suspect he's had a stroke. He's unable to give information and has no ID on him. I have a couple of things I want to bring to your attention in this scenario. First of all, when you're coding for the emergency department, this falls under outpatient guidelines. So the fact that a doctor says he suspects the patient's had a stroke, you do not code that stroke as if it's occurred. This is covered in B, which is general coding guidelines, under the topic uncertain diagnosis. If this patient were an inpatient and the doctor has said, I suspect he's had a stroke, then the coder would code stroke. So now to the hypertensive emergency. The doctor did use those terms, so the coder could code a hypertensive emergency, I16.0. Now in this case, notice our guideline says code also any identified hypertensive disease. The doctor did not mention this. He doesn't know if this patient's had hypertensive disease, although it's probable. But again, I would not want to assign that unless the doctor had mentioned it to me and said, yes, code hypertension. I think more guidelines will come out on this through the coding clinic in the next year. Anytime you have a new guideline and coders get used to using it, questions come up. And those are the types of questions that are covered in the coding clinic. The next guideline has to do with atherosclerotic coronary artery disease and angina, or angina. This is just a guideline telling us that there are codes for different coronary artery disease that include angina. Coronary artery, of course, is the artery in your heart, and it can become blocked with plaque or clots. But when it's plaque, it's typically an atherosclerotic coronary artery disease. And you also notice the two combination codes are given in the guidelines. I-25.11, which is for atherosclerotic heart disease of a native vessel, meaning the patient's own vessel with angina, or I-25.7-, which is atherosclerosis of a coronary artery bypass graft and coronary artery of a transplanted heart. So that second code, I-25.7, is for atherosclerosis of coronary artery that is not the patient's own artery or original artery they were born with. I-25.11- is the heart disease of the native coronary artery, both of these with angina. When you're using one of these combination codes, it is not necessary to use an additional code for the angina. A causal relationship can be assumed in a patient with both atherosclerosis and angina unless the documentation indicates the angina is due to something else. If a patient with coronary artery disease is admitted due to an acute MI, then the acute MI should be sequenced before the coronary artery disease in your list of codes here. Next guideline, intraoperative and postprocedural cerebrovascular accident. Intraoperative means the stroke has happened during the surgery. Postprocedural, it has happened after the surgery. The scenario we're given is an embolic cerebral infarct of the right middle cerebral artery that occurred during hip replacement surgery. So it's intraoperative, and the surgeon documented as due to the surgery. So your infarct, the intraoperative, is I-97.811. You see the term during other surgery. That's because when you look in your list of codes in the tabular, the first code has to do with during cardiac surgery. So during other surgery is identifying any surgery other than cardiac. Then we code the cerebral infarct due to the embolism of the cerebral arteries. And in the tabular, the fifth character 1 is assigned for the middle cerebral artery, and the sixth character 1 signifying it is the right middle cerebral artery. Again, if you follow your instructional notes in the tabular, it will often help you find the right code. Just a note here, in your guideline, the medical record documentation should clearly specify the cause and effect relationship, which it did in our scenario. The surgeon documented that the cerebral infarct was due to the hip replacement surgery. You're not going to always have that, so you may not be coding it. You cannot assume it. You also notice the proper code assignment depends on whether it was an infarct or a hemorrhage. So be careful when choosing those codes, because your code assignment is going to depend on the type of procedure performed. The next guideline has to do with the sequelae of cerebrovascular disease, which would be, for example, hemiplegia that continues after someone's recovered from a stroke. You do not use this I-69 code for a patient who is in the hospital right now with a stroke, having had a stroke. That would be a G code for hemiplegia. Your I-69 code is particular to that patient who has a sequela or an existing hemiplegia after discharge from the hospital, recovering. They've had the stroke, they've recovered, and they still have this weakness on one of their sides. In this particular scenario, the word old tells the coder we're looking at sequela, and we know from our guidelines that category I-69 is used when coding sequela. Then I make a note here in the rationale to just make a point of always remembering this is a deficit that's persisting after the patient's been discharged. You also notice at the bottom of the guidelines we talk about how you choose that sixth character, which indicates dominance. When the scenario or the medical documentation does not tell us which hand dominant, then we're going to use this guideline here that tells us if the right side is affected, the default is dominant. So we're going to claim that it is the right side dominant for this patient with right side hemiparesis. This is more notes on category I-69. Codes from category I-69 may be assigned on a healthcare record with codes from I-60 through I-67 if the patient has a current CVA and deficits from an old cerebrovascular disease. So the patient has a previous stroke with right hemiplegia, then he comes in with another stroke, and now he's got left hemiplegia. The left hemiplegia with the current stroke is not going to be an I-69 code. The old stroke is going to be the I-69. Also notice in the second bullet point, codes from category I-69 should not be assigned if the patient does not have neurological deficits. That is only used when you have that sequela from the stroke with the hemiplegia. This guideline has to do with STEMIs and non-STEMIs. An acute inferior non-STEMI evolved into a STEMI. And our guidelines tell us when this happens, we code it as a STEMI. And that's what your index pathway shows you there. The time frames when you are coding myocardial infarctions are important. And I have it in purple there so that we remember that. 4-week time frame is the magic number there. The guideline we're going to cover is the subsequent acute MI. This is when a patient has had an MI within that 4-week window of the initial MI. When that happens, if your treatment is focused on the subsequent, then that's going to be your principal diagnosis, and that is in category I-22. And then you must also remember to keep coding that first MI that happened within the 4-week window, and that's an I-21 category code. As it says, the sequencing depends on the circumstances of the admission. When I give you these scenarios, I tell you how the treatment is focused. It's not going to be that explicit when you're reading a medical record, but you'll be able to tell from the physician's progress notes how the treatment is. It's an oversimplification when teaching you coding, but I don't think it would be very productive to hand someone who's new to coding an entire medical record and say code it. You really have to learn phrases and terms, which documents to look for, to be sure that you're capturing all the codes that apply to the given scenario. In my coding education, we were always told you're telling the story. You're choosing the codes that tell the story. That's still true, but you have to follow the guidelines to know the sequence of the codes and being sure that you are paying attention to the notes, the instructional notes that are written in the tabular, to be sure you're capturing everything that goes together. If you have any questions about the Chapter 9 coding guidelines, please post them in the discussion board and I will answer them for you. Have a nice day.